All right, welcome back. Today, we're going to tackle two diseases that are classic board exam fodder, and honestly, they're super easy to confuse. Acute Intermittent Porphyria and Porphyria Cutanea Tarda. So let's just dive right in with a couple of cases. Okay, so let's set the scene. You're in the ER, and a young woman comes in with this just excruciating abdominal pain. It's vague, it's diffuse, and her physical exam is totally normal. She's also acting a little weird, anxious, kind of confused. And when you dig into the history, you find out she just started a new medication. To top it all off, her family says her urine looked really dark, almost like port wine after it sat for a bit. Okay, now totally flip the script. You're in your outpatient clinic, and a middle-aged guy walks in. He's got these chronic, painless blisters all over the backs of his hands and forearms. You know, the parts that see the sun. He mentions they're super fragile and just take forever to heal. And almost as an afterthought, he says, "Oh yeah, my urine has been kind of tea-colored lately." So here's the kicker. Both of these patients have a porphyria. They both have a problem with making heme. But one is in the middle of a life-threatening neurologic crisis, and the other has a chronic skin issue. They're worlds apart. So what gives? Why are they so incredibly different? That's the puzzle we're going to solve today. Okay, so here's our game plan. We'll start by talking about how these two fit into the same disease family. Then we'll get into the nitty-gritty of the heme synthesis pathway. We'll have a clinical showdown between AIP and PCT, talk diagnosis and treatment, and then, of course, finish up with some high-yield exam pearls you won't forget.
So, first things first, what is the common thread here? What even is a porphyria?
The easiest way to think about porphyrias is to picture a factory assembly line. Your body has this 8-step process to build heme, which is absolutely vital. In porphyrias, one of the workers, one of the enzymes, on that line is broken. This causes a major traffic jam, and the raw materials, these intermediate compounds, start piling up. And these backed-up precursors, they're toxic. The key is which one piles up. That's what determines if you get a neurocrisis or a skin problem. So let's get a closer look at that assembly line. We're going to pinpoint exactly where things go wrong for each of our patients and why those different blockages lead to such different outcomes. So here it is, the heme synthesis pathway. The most important thing to see here is where the defect is. For AIP, the problem is way upstream, early in the process. The enzyme porphyrobilinogen deaminase is busted. For PCT, the problem is much further down the line, at the uroporphyrinogen decarboxylase step. So you have an early-stage problem versus a late-stage problem. And believe me, that location changes everything. In this right here, this is the whole story. In AIP, that early blockage causes a backup of two specific precursors, ALA and PBG. And these guys are straight-up neurotoxic. They mess with their nervous system, causing all that pain and confusion. But in PCT, that later blockage causes a backup of a totally different compound, uroporphyrins. These aren't neurotoxic at all. Instead, they're photosensitive. They travel to the skin, and when sunlight hits them, they basically explode into free radicals and cause damage. So you've got neurotoxins versus skin-damaging photosensitizers. All right, now that we've got the science down, let's put these two conditions head-to-head and see how that basic difference plays out in the clinic.
So let's look at PCT first. This is what you see. These fragile, painless blisters on sun-exposed skin, like the back of the hands. This is literally what happens when those photosensitive uroporphyrins get hit by sunlight. The skin becomes so fragile that even a tiny bit of trauma can cause these big blisters, which then break and heal really, really slowly.
And AIP? Well, it's the complete opposite. It's an internal crisis. There are absolutely no skin findings. Zero. Zip. All that chaos is happening on the inside as those neurotoxins, ALA and PBG, attack the nerves that control your gut, causing that horrible abdominal pain and your brain, leading to all the psychiatric symptoms. Okay, this slide right here, this is pure gold for your exams. It lays everything out side by side. You can see the pattern, right? AIP is an acute attack. It's neurologic. PCT is a chronic condition. It's cutaneous. And check out the triggers. This is super high yield. AIP gets flared up by things that rev up that heme factory, like certain drugs or fasting. PCT, on the other hand, is made worse by things that hurt the liver, like alcohol or hepatitis C. Totally different triggers. Now, here's another classic finding in PCT you might see on an exam. Besides the blisters, patients can get hypertrichosis. It's this fine, excessive hair growth, usually on the sides of the face and the temples. It's a really weird but very characteristic sign. And since PCT is a chronic thing over years and years of sun damage and blistering, the skin really takes a beating. You start to see significant scarring, weird patches of light and dark pigmentation, and the skin can even get kind of thick and waxy. It's the result of all that long-term inflammation.
All right, so you're thinking porphyria, what now? How do you lock in the diagnosis? And more importantly, what are you going to do about it? Let's get into the clinician's toolkit. The cool thing is the diagnosis flows directly from the science we just talked about. For AIP, you're looking for those backed up neurotoxins, right? So you order a urine test for PBG and ALA, and during an attack, those levels will be through the roof. For PCT, you're looking for the photosensitizers, so you measure uroporphyrins in the urine. It just makes sense. Okay, listen up because managing an AIP attack is a true medical emergency. First, stop any drug that could be a trigger, immediately. Next, you give them a big load of carbs, usually as a glucose infusion. That helps tell the factory to slow down a bit. But the real lifesaver is intravenous heme. Giving heme is like flooding the end of the assembly line with the finished product. The factory gets the message loud and clear. Whoa, we have way too much, and it slams the brakes on production, which stops the buildup of the toxins. The treatment for PCT couldn't be more different. We're not in an emergency here. It's all about long-term management. The number one thing is to get rid of stressors on the liver, so tell them to stop drinking alcohol. Then the go-to treatment is, get this, phlebotomy. We literally take blood out of them regularly. Why? Because too much iron makes PCT worse. By taking blood, we force the body to use up its iron stores to make new red cells, and that helps the broken enzyme work a little better. It's a pretty low-tech but super effective solution. All right, let's wrap this up and drill down on the stuff that's going to get you points. Here are the unforgettable exam pearls. For AIP, it's all about the 5 Ps. Just burn this into your brain. Painful abdomen, port wine urine, polyneuropathy, psychological symptoms, and precipitated by drugs. If you see that combo in a question stem, your brain should scream AIP. Don't even hesitate. And for PCT, it's even easier. The buzzword phrase is chronic, painless, photosensitive blistering. You see a patient with blisters on their hands after sun exposure, maybe they drink a little too much, boom, that's PCT. So let's bring it all home with one final summary. The simplest way to think about it is this. AIP is an inside job. It's an acute neurologic emergency caused by an early defect, and you treat it urgently. PCT is an outside job. It's a chronic skin condition caused by a late defect, and you manage it by dealing with lifestyle triggers and iron overload. So there you have it. They both have porphyria in their name, but one is a slow-burn chronic disease, while the other is an absolute life-threatening emergency. Knowing the difference isn't just about getting a question right on your exam. It's about recognizing a crisis and potentially saving a patient from permanent neurological damage. Hopefully, after this, you'll spot the difference every single time.